Our next speaker is Megan Abbott from Colorado, and she's going to be talking about the STXBP1 clinical severity assessment scoring, but from the caregiver scoring this time.
Hi, everyone. Like he said, I'm Megan Abbott. I'm from Children's Colorado, and I'm very appreciative to have been asked back to talk about the STXBP1 clinical severity assessment. But today, we're going to be talking about the caregiver clinical severity assessment. So throughout the day, we've heard a lot about the SCSA, and I appreciate all my collaborators' call-outs throughout the day. That was very nice. Most of the correlations that have been shown with other measures in the STAR study are dealing with the SCSA clinician assessment, which is essentially a graded neurologic exam that we call the STXBP1 clinical severity assessment clinician version. And I presented that data last summer and then in Heidelberg, and so today I'm really going to be focused on the caregiver reported measure. So it's just a little bit of a different measure when we talk about the SCSA caregiver, so I just wanted that to be clear before I start. So for my talk today, we're going to go through the need for the caregiver perspective, which I'm just going to brush on because I think we've heard a lot about that today. Go through the creation of the SCSA caregiver, and then review results so far through the STAR study. So why do we need a caregiver measure? Patient perspective, why would that matter? I think this is not a hard argument to make at this point, but parents report concerns apart from what we've been traditionally measuring in clinical trials. So when we look at patient-focused drug development meetings across conditions, parents are reporting concerns in lots of domains, not just epilepsy. So global developmental delay, feeding challenges, speech challenges, difficulty walking, sleep, across functional and symptom domains. Parents report these are top concerns that they want measured in a clinical trial. And this was corroborated in the STXBP1 disease concept model that we've heard a lot about today as well, where both healthcare providers and caregivers rated many domains as being important and things that we should be measuring in STXBP1. So we need to address concerns that are top concerns for parents. We need to be measuring things that matter. If we're going to be doing clinical trials, especially high-risk gene therapy trials that we've been talking a lot about in the last 2 days, then we need to make sure we're having improvements in these different domains and that we're not just, hitting a single, but that we're really hitting a home run and that we're going to see improvements in multiple domains if we're going to put patients and families through the risk of the kind of intense trials we've been talking about. And we need to be able to measure small and meaningful changes as well. So we've seen a lot of Vineland data today in STXBP1 and in other conditions have shown that raw scores and standard scores have unique challenges and that we need to be looking at alternative ways of using off-the-shelf measures like GSVs. And that we have a lack of outcome measures validated in neurogenetic conditions. So given all of these things, we decided as a group to try to make severity assessments aimed for STXBP1. So talking through the caregiver measurement, originally designed within the CDKL5 U01 study, termed the CDKL5 Clinical Severity Assessment, or CCSA, went through a very rigorous validation process in CDKL5, where both the clinician and the caregiver severity assessment were taken through this kind of cross-sectional and then longitudinal validation effort. And I like to throw this up there because we've been talking about measurements all afternoon. And I think when people say that a measurement is validated, that's a spectrum. So in measure validation land, a measure's never really truly validated. You're not really ever done. But the goal is to move forward on this process. So to go from deciding that a measurement is fit for purpose, meaning that it is appropriate for that condition and it's also appropriate for the setting you're using it in. So trying to think about measurements that are appropriate for STXBP1 and appropriate for the clinical trials that we're going to be using them in. And then moving forward into both reliability and validity testing, and then getting into longitudinal data, which we've been talking about a lot today, is needed in STXBP1. So the caregiver severity assessment has 4 domains. It has epilepsy, behavior, alertness or interaction, and feeding. And I want to give some examples of items within the measurement just to give some flavor, go through the scoring, and then look at some of the data that we have already. We think that the epilepsy domain of it is quite unique in that we are trying to rate both seizure frequency and seizure severity over a 30-day recall period. So we know that seizure diaries have a lot of challenges in terms of caregiver burden throughout a study and also kind of the reliability of doing a seizure diary every single day. And the hope is that we could do a 30-day recall and still get a good capture of how frequent seizures have been, but also how impactful seizures have been. So a seizure diary will tell you how frequent a seizure is, but not necessarily how impactful that seizure has been to the family or to that individual. And so this initial item is showing frequency of seizures over a 30-day period. And then getting into kind of how disruptive those seizures have been to a child's routine and what the child's longest seizure-free period has been. And I'm going to pause here just to go over the scoring. So the SCSA is a little bit unique in that the scoring goes from being a 0 to the least amount of impairment to 100, which is the most impairment. So if you look at this first item, my child has not had any seizures in the past 30 days. That would be rated a 0. To has had seizures every day for the past 30 days. That would be a score of 100, and then gradiated in between. So the higher the score, the more severe your impairment on the SCSA. And then moving on to the alertness or interaction domain. So how interactive has the child been with other children? How interactive has the child been with family members? What kind of eye contact has the child had? These are the kind of items in this domain. And then behavior, which we're all kind of trying to figure out how to measure best, because obviously behavior is a challenge throughout a lot of neurogenetic conditions, including STXBP1. And so how aggressive has the child been? And then once again, I think the beauty of the measure and what we're trying to do is how impactful are these things on the family? How impactful are these things on day-to-day? So really getting at the severity of some of these symptoms, not just are the symptoms present. So how often has your child's challenging behavior how often has your child had challenging behavior outside the home or in the community? And just really trying to get at is that behavior limiting a family's interaction with the outside world. And then feeding, so what is G-tube status like? How has swallowing been? Are there aspiration concerns? Once again, gradated on a scale of 0 to 100, with 100 being the most impairment. So I'll show some initial data and then give a ton of caveats, so everyone hang with me for a little bit. I will say that for these graphs, my x-axis is the SCSA score, so going from 0 to top scores. And then on the y-axis is the number of patients falling into each of those buckets of scores. And you will see that for all of these different domains, there are a lot of patients at 0, meaning that a lot of patients or a lot of parents or caregivers rated their patient as not having symptoms in that domain. I actually think some of this makes a lot of sense. We heard today that if you sample a random time point for STXBP1, not a lot of patients are having seizures, right? It's a small percentage of the cohort at any single time point that are having seizures. However, if you look at an individual patient on patient-level data, that patient may be having symptoms in feeding, that patient may be having symptoms in alertness, but across the cohort, there are a good amount of patients at that 0 level or not having any symptoms. And so I just wanted to focus in on the patients having symptoms in these domains, so that's what the brackets are for. So if you look across epilepsy, alertness, behavior, feeding, you can see that for patients having symptoms in each of these domains, there's actually a decent distribution. So there are some patients at that 10 to 15 or less severe end of the scoring range, and patients also at the very high or severe impairment range of the score, going all the way up to like 95 or 100 in the alertness domain. And so while it does look and is true that there is a ceiling effect, meaning that a large majority of the cohort is at that 0. And it is weird to call 0 a ceiling effect, I acknowledge. But because 0 is the least impairment, the correct term is actually that this is a ceiling effect. I think if you take patients out who are not experiencing symptoms and really focus on the patients experiencing symptoms in these domains, you see kind of that we're capturing a range of severity across these symptom domains. I then just wanted to look at patients who have had at least one lifetime seizure, because percentage of the cohort, about 20%, had not experienced a lifetime seizure. And so if you pull out the patients, so 57 out of that initial 68 that have had at least one lifetime seizure, you see that you lose a little bit of your ceiling effect, so a lot of those less severe scores go away, but you keep your broad range of severity across symptom domains. And so just showing that patients who've had a lifetime seizure may be kind of an overall more severe cohort, and that you're still seeing that kind of broad distribution of scores across severity. That continues to be true when you're averaging all these scores together. So you can take averages of the domain scores, so your epilepsy, alertness, feeding, and behavior domains, and then average them together into a total score. And when you average it all together, you do see less of a ceiling effect, especially when you once again separate out patients that have had at least one lifetime seizure. You see a nice broad band of severity across scores. Yeah, and just looking at this, so mean was about the same across all the different domains with similar standards of deviation. You have nice minimum and maximum scores for each domain, showing that patients did show minimum severity and maximal severity across these different domains. And that's true for all the domain scores as well as the total. So overall, while there are some challenges with caregivers overall rating some patients as not having any symptoms in various domains, I think caregiver reported outcome measures that capture symptoms meaningful in STXBP1 are still very important. For patients with symptoms present in these domains, there was a nice distribution across the scores of severity, and that patient and caregiver outcomes continue to be important as we look towards clinical trials. And with that, I want to say thank you. I wanted to say a short plug that this community has been very welcoming to me as I've become a scientist and really welcomed me with open arms, and I really appreciate that. And you guys have watched my family grow over the last 2 years, so I just wanted to show some updates. The twins are now 2, crazy, and just very appreciative of the foundation and the families and all the colleagues that I get to work with. Thank you.